It's a great pleasure to introduce Beat Möckli. He's a third-year resident in our clinic. He started his training in the US and joined us recently, a few months ago. And he will be talking about an important topic and about colon obstruction. Thank you very much. We're looking forward to your talk.
Thank you for the introduction and welcome to the resident lecture this morning about colon obstruction. I'd like to start out with a case presentation. It's a 43-year-old female who presented since the morning with acute abdominal pain. She has a remarkable past medical history for personality disorder and several suicide attempts, no previous abdominal surgeries, and no medications. On exam, she has a diffusely tender abdomen, a tympanic abdomen, but no peritonitic sign. CT scans performed and shows the following picture. Does anyone have any ideas about the differential diagnosis at this point?
I think there's some kind of obstruction.
Exactly. We'll come back to this case presentation at a later point to talk a little bit more in detail. A quick overview of the presentation. We'll start out with some numbers about the epidemiology. Then we'll go into mechanical obstructions with colorectal obstruction and different kinds of volvulus, represented here by malignant colorectal obstruction. Then we'll go into pseudo-obstructions with the Ogilvie syndrome, represented here by these dilated proximal colon, and then into toxic megacolon effusive colitis and ulcerative colitis. And we'll round up the presentation with some conclusions and bullet points. So about epidemiology, about 10% of all patients who present to the ER present with some kind of abdominal or intestinal obstruction. This can be small bowel or also large bowel. Of these, about 1/4 or 25% are colon obstruction. 75% of these require some kind of surgical intervention at some point during the hospitalization or during the hospital course. The large majority of the colonic obstruction are due to malignant disease, 70%. And then cecal volvulus, sigmoid volvulus, and diverticular disease each are responsible for about 10% or a little less than 10%. But there's also a myriad of causes that can cause colorectal obstruction or distal colonic obstruction, and we'll go into these different causes a little later as well in the presentation. So first, mechanical obstruction. What's the patient population we're dealing with patients that present with acute obstruction or acute colonic obstruction? For sigmoid volvulus, these are more commonly older patients, more than 70 years of age. They have some kind of neuropsychiatric disorder that's certainly a risk factor. They're often institutionalized. They have chronic constipation and some kind of chronic dysmotility. Also, a longer sigmoid and kind of a different patient population is a risk factor. For cecal volvulus, this often affects younger females between the age of 30 and 60, so kind of different population. For colorectal cancer, the age at presentation is quite old, it's 73 years old, and 30% of all patients who present with a colorectal cancer present with some kind of obstructive symptom, which is kind of surprising given that there's a routine screening in place. The patient presentation is a little more insidious than for small bowel obstruction. It's quite nonspecific, can be bloating, abdominal pain, obstipation. The clinical exam shows distension, tympanism. This doesn't mean that patients cannot present with acute picture, with sepsis, even abdominal compartment syndrome, or signs of shock. But that's certainly the minority. The majority is more nonspecific and not as acute as for small bowel obstruction. Next, I would like to go over some imaging, some typical imaging pictures for colonic obstruction or for volvulus. Here, the first one on this barium enema. Does anyone have an idea what that could represent or how this sign is called? Maybe one of the students.
I think omega sign.
Omega sign? I've never heard of that. Possible. But what you can see here actually is a bird's beak sign. I guess that's how the sign is typically called. We can see the barium rising up here, but the torsed sigmoid that doesn't let the contrast through. also illustrated here by a bird's beak. Next, we have this abdominal radiograph, this abdominal X-ray, very typical sign as well. Anyone have an idea here?
A coffee bean sign?
Exactly, coffee bean sign, and that's typical for a sigmoid volvulus, but can also be for a cecal volvulus. And then next, this structure here of the torus mesenterium, which is typical for any kind of colonic volvulus, so can be sigmoid or cecal, and that's a rural sign, also very typical. And at the same time, these three imaging modalities also represent the tools we have available for the workup of colonic obstruction. So this is barium enema and then abdominal x-rays, which are very handy to follow a patient over time, easily available and easily performed, doesn't take a lot of time. And then kind of the gold standard that we have today, which is the CT scan, very specific and very sensitive. We'll come back to the case presentation in the beginning that we talked about quickly. So the patient underwent the CT scan, it showed the cecal volvulus, and it was decided to take the patient to the OR at this point. The gold standard for the treatment of cecal volvulus is right hemicolectomy or ileocolic resection, and that's also what the patient underwent. In some cases, conservative management can be attempted, but it's not really recommended. There's a high risk of perforation with, for example, colonoscopy, and colonic necrosis can be missed in up to 20 to 25% of the patients. Here we see intraoperative pictures from the resection that the patient underwent with the torus segment of the bowel that you can see here. And then here the detorus bowel, but some necrosis in the cecum here, right before the perforation. The patient underwent the resection and did fine after. The picture looks quite different for the sigmoid volvulus. There's a different treatment algorithm, and operative management may be at the later point. It's not at the forefront for this picture. So once the diagnosis of a sigmoid volvulus is made, if there is evidence of bowel ischemia, obviously the patient needs to go to the operating room. However, if there's no evidence of bowel ischemia, endoscopic detorsion can be attempted first. If that is successful, a rectal tube can be placed and the sigmoid resected during the same admission in an elective setting or in a semi-elective setting. If there is ischemic changes on the endoscopy, patient needs to go to the operating room, or if the endoscopic detorsion is unsuccessful, patient needs to go to the operating room as well. If once the diagnosis or once the decision is taken to go to the operating room, there's different modalities or different surgical strategies available. It can be done laparoscopically or also open. Next, I would like to go over a paper or a study from Van der Naal et al. He performed a study in Africa where the incidence of sigmoid vulva is much higher in young, otherwise healthy males because of a anatomically longer sigmoid. And also the setting is kind of particular that they don't have routinely endoscopists available, and there's a need for definitive surgery, so because of the distances between the medical centers and also the patients. He performed what he did and what we also do here sometimes. He did a mini laparotomy infraumbilically. He managed to mobilize the whole colon through this small incision, 5 to 7 centimeters, performed a resection and then a hands-on anastomosis with a total OR time of less than an hour. He didn't do any preoperative decompression and managed to do this procedures operation safely in the 31 patients that he did with a low morbidity and mortality overall. Next, I'd like to quickly go over a second case presentation. It's the one of a 74-year-old male who presented with acute or kind of more chronic abdominal, lower abdominal pain that has been present for a week, so a little longer. Also some nausea, diarrhea. Past medical history is quite unremarkable. No previous abdominal surgeries, no medications. On exam, he has a bloated abdomen, high-pitched bowel sounds, and a panic sign. CT scan is performed and shows the following picture. Also a very typical sign an apple core lesion in the distal colon. So the diagnosis of a colorectal cancer is made, and the patient underwent the resection during the same admission. This brings us to the next topic, which is colorectal malignancy. In Switzerland, about 1,000 patients present yearly with obstructing or some kind of obstructing symptom with colorectal lesions. Most lesions are located distally, about 40% in the sigmoid colon, 10% in the rectum, and 5% in the anus. CT is the imaging modality of choice. It has a very high sensitivity and specificity, and definitely has taken over from barium enema for the main workup for these patients. What about the surgical management? I'll quickly go over some treatment strategies for these patients presenting with a colorectal malignancy and some obstructing symptoms. First, obviously, the patient needs to be resuscitated, electrolyte needs to be corrected, and then a surgery needs to be performed in an emergent or semi-emergent setting. If the patient presents very dramatically, has signs of shock, is very ill, has a high chance of neoadjuvant chemotherapy, or has a high comorbidity load, a Hartmann procedure is indicated with resection of the lesion and then an end colostomy. However, if the patient presents with a right-sided lesion, is otherwise healthy, has incomplete obstruction, and no or low comorbidities, a segmental resection can be attempted. However, if the patient has synchronous lesion in the left colon or has some compromised left-sided, a subtotal colectomy can also be indicated. And Dr. Kaiser actually published on that in 2012 and showed that this can be done safely with a low leakage rate. And next we'll quickly go over kind of a hot topic in the field, which is colonic stenting. It has previously proposed as a bridge to surgery, allowing for complete staging and also avoiding surgery in disseminated disease. Here we have the first multi-centric randomized controlled trial, which was published in 2011 by a Dutch group. They included 98 patients with severe left-sided obstruction that's been present for at least 1 week. They excluded patients which were already perforated, had a lesion that was very low, less than 10 centimeters from the anal verge, and high comorbidity load. Their findings were quite surprising that the trial had to be stopped because of higher morbidity in the stent group. They had a high perforation rate, which was 20%, and also a higher leakage rate. What was a little special about this study, that they included all the complications from the stent placement, but also from the resection that was done during the same admission. So not only the stent placement, and compared this to the initial resection. Also for the perforation, they included silent perforation that were detected on resection. So not only frank perforations that presented immediately, but also perforations at the later point. Also surprising was that they had a low technical success rate of only 70% successful stent placement, which was much lower than previously reported. This might have been due that a high rate of these patients were presenting with complete obstruction. They didn't find any difference in mortality or stoma rate at 6 months, and also no difference in quality of life. So in summary, I think colonic stenting definitely needs to be treated with caution, can have a place for a very select group of patients, but overall is not the miracle treatment that has been proposed earlier. Next, I'll just quickly go over some other causes of mechanical colorectal obstruction. These can be very different, a myriad of different causes. Can be endometriosis, Crohn's disease, diverticulitis, which is actually the most common of all the other causes. Anastomotic stenosis, hernia, retroperitoneal processes or malignancies, and also gallstone ileus with a few case reports reporting this as a possible cause. Next, I would like to go on to colonic pseudo-obstruction, here represented by Ogilvie syndrome and toxic megacolon. Ogilvy syndrome is a pseudo obstruction that is not caused by a mechanical, or it does not have a mechanical cause of obstruction. It's more common in the proximal cecum and the right colon and affects mostly older patients. It's first been prescribed in 1948 by Sir Ogilvy, who published 2 cases of retroperitoneal cancer with celiac plexus invasion and parasympathetic deprivation. Often these patients present with trauma, with fractures, obstetric trauma, very complex medical patients with MIs, pneumonias, or chemotherapy, also retroperitoneal malignancy as described first by Ogilvy can be a cause. In addition, electrolyte imbalances and some narcotic medications or calcium channel blockers need to be present as well. The diagnosis consists of routine lab. If there is diarrhea present, stool cultures need to be taken to rule out C. diff colitis. And then CT imaging is the modality of choice, the imaging modality of choice. This is to rule out the mechanical obstruction and then also to diagnose any other form of intra-abdominal process, like, for example, retroperitoneal malignancy. The treatment algorithm, we went over this morning report, I think, 2 weeks ago, quickly. So here again, if there's acute colonic distension present, mechanical obstruction needs to be ruled out first. That's kind of the first step that needs to be done. If there is a pseudo-obstruction present, conservative management with IV fluid, angiotube, and then MPO can be attempted. And obviously treat any reversible causes. If there's partial or no response, neostigmine can be administered. And actually, Ponek and al. Showed in 1999 that 17 out of 18 patients responded to neostigmine with a complete resolution of the colonic distension. However, if there's no or partial response, colonic decompression with the placement of a rectal tube can be attempted. If there's still no response, surgical management needs to be evaluated. Indications for surgery right from the beginning are obviously perforation, peritonitis, or then a cecal diameter of more than 12 centimeters, since studies have shown that if the diameter goes above 12 centimeters, the risk of perforation drastically increases. Here are also some pictures. These pictures are actually from the publication from Ponek et al., and they show here first dramatic colonic distension, and then 24 hours later, after the administration of neostigmine, a complete resolution of this distension. Next, we'd like to go on to toxic megacolon, which is defined by colonic distension and diarrhea. Also, 3 factors of this box need to be present with a fever, tachycardia, leukocytosis, or anemia. And then 1 factor, this box here, with dehydration, electrolyte imbalances, hypertension, or altered sensorium. Often these patients are very ill, and colonoscopy for a workup is not recommended given the high risk of perforation. Toxic megacolon has kind of 2 different etiologies, 2 different causes. One of them is IBD, or most commonly ulcerative colitis. Often these patients present very early in the course of disease, 30% within 3 months, and then 60% within 3 years. Signs of colitis often are present before the onset of toxic megacolon, and an improvement in diarrhea might actually herald the onset of this megacolon. What you can see here is, again, diffusely dilated colon, proximal colon, with haustral markings that do not extend over the whole colon, which is very typical for toxic megacolon. Also, abdominal radiographs are very critical for the follow-up of the patient, since it's easy to follow and easy to perform study. The treatment is quite straightforward. These patients are often very ill. They need bowel rest, an angiotube, often ICU monitoring given their state. High-dose IV corticosteroids can actually be given. There's no increased risk of perforation with this. Studies have shown that. And then broad-spectrum antibiotics. The patients need to be evaluated for surgery if there's no, or if this disease progression or no improvement on best medical management. The other etiology is actually C. diff infection. It affects 1% of all hospitalized patients, with 0.3 to 4% actually going on to develop toxic megacolon. There can be a rapid progression from fulminant C. diff colitis to death, so definitely these patients need to be evaluated surgically. There's no clear-cut lines or guidelines when to take these patients to the OR, but some papers have proposed leukocytosis over 15 or 20,000 and then a lactate of over 5. However, there's been a high surgical mortality rates for fulminant C. diff colitis, up to 35%, and a lot of doctors are hesitant to actually go on to do present surgery. For the medical management, first, the inciting antibiotic needs to be stopped. Then an antibiotic treatment with oral vancomycin and IV flagyl needs to be started, and the patient evaluated for surgery. And next, I would like to present one treatment strategy that has actually been proposed in 2009 by Neil et al. What he performed was a diverting loop ileostomy, and he performed colonic lavage for 10 days with vancomycin enemas. In 43 patients, it was a prospective single institution study, no control group. And he had quite surprising results. He had a drastic reduction in mortality to 90% from 50. And 70% or close to 80% of the patients had a successful reversal of the ileostomy within 6 months of the operation. However, the study had quite a few limitations. It was single institution, there was no control group. He had a small number of patients, and to date, no study has managed to reproduce these drastic reduction in mortality. Certainly, larger RCTs are needed to confirm these results and establish this therapy in the clinical practice. So already at the end of the presentation, I'd just like to go over some take-home messages. CT imaging is the modality of choice in colorectal obstruction. Both Hartmann's procedure and primary stenosis are valid options depending on the patient population and depending on the presentation. Caution should be used with colonic stents. Conservative management is at the forefront for pseudo-obstructions. Here is an example, the high success rate for neostigmine, and then that there are different surgical options for C. diff colitis, and that these patients need to be evaluated for surgery given the possible fulminant course. And that's it.
Thank you very much for this very nice overview. Thank you. I have just 2 comments, maybe. You present all those things. There are emergency settings, so I think it's a relevant topic to everybody. And the first comment is about stenting. You nicely showed that these treatment is not very successful. Initially, there was very enthusiastic about this stenting. And we have more and more data now that show that this is not really the treatment of choice in these patients with colonic malignant obstruction. So this treatment has largely been abandoned. There are very rare cases where patients cannot be operated or have an anticoagulation that cannot be stopped or anything like that. Then stenting can be an option, but that has very rare cases. And the second comment is about toxic megacolon, very important topic as well. Has become very rare due to the good treatment of IBD population with our gastroenterologist. But we have a few rare cases that present with toxic megacolon, and they need to be picked out. So are there any questions?
Well, I mean, number one, I think congratulations. A very difficult topic. You did difficult, it's common, but you cover a lot of different options, a lot of informations. And I think here that's also important in training. This is good to learn in book, but you need to see the patients. I think the way to really know this for resident and always to be involved in these cases to follow the cases and to learn. And this is one example with the limitation of hours and whatever that I think many people don't have the expertise they should have in that, and the one who may suffer from that are patients. That means all of us. One day we may go in centers where the resident or maybe the other one who will treat me or treat us has seen one or two, and that makes a big difference. I mean, this is a lot of information here, but the reality with these patients sometimes really need some experience. I have two questions. I wanted, in fact, to ask the stent, because I'm a bit surprised, and I would not be surprised that in 2 or 3 years come another paper and stent is the way to go. And I have example, I'm not very much involved with this patient, but I have at least 2 patients, one who really, I think, benefit so much from a stent. They came in acute obstruction with left cancer, stent, they were and then operated in a delay manner, and then did not have a stoma and did extremely well. So that's just cases. So I think I will caution. I think I did not do not read all the literature. I was not aware about this study from the Netherlands, but there's a lot here of techniques, the ability of the people to place the stent, etc. So, I mean, here I would not suggest that the stent is the gold standard today, but I would not be surprised that very soon someone, group come with either a better stent or better technique, and it becomes the standard, because that's an obvious way for me, someone to bridge, to let the patient recover a little bit, and then to do maybe less invasive, better oncologic operation. That what we are doing here. Maybe one comment about the enema. Just tell us, because many of these patients arrive with megacolon or the Ogilvy or whatever, and then they have some enema or they have colonoscopy and disaster. The few cases I can remember was in fact colonoscopy in some of these situations and end up to absolute disaster. Here. So maybe I would like to insist on some recommendation here about colonoscopy or even enema in the real world of this patient presenting with some sort of obstruction in this.
Yes, thank you very much. It's a very important issue about the colonoscopy should be performed with caution. There are rare cases where colonoscopy can be performed and should be performed. For example, in pseudo-obstruction, colonoscopy can be performed if conservative measures are not successful. You need to have an experienced endoscopist, and they usually perform the endoscopy with water. In these cases, they can perform a decompression and then actually save the patient from an emergency operation. In other cases, for example, like malignant obstruction, we are very conservative with colonoscopy because there's an air trapping behind the stenosis, and we have several cases where the cecum has been blown up and actually perforated. So we are very conservative in those situations. And that's the same thing that what you mentioned with the stenting. That's also a problem when they place the stent, that there's an air trapping, and the colon behind, especially the cecum, can be dilated and perforated. So that's one of the reasons why stent placement and colonoscopy in these settings should be performed in very selected cases. But as you mentioned, there are also some nice examples where the stent placement had a resolution of the problem, and an operation in an elective setting could be performed.
You show here for the pseudo-obstruction that the diameter of bigger than 12 centimeters you should resect, but is there a cutoff until when you can do the decompression of these patients?
To be honest, no, there is no such limit. There's also no limit where you should do a resection, like 12 centimeters. That's kind of arbitrary. So this is mainly also a clinical decision. When you should do a colonoscopy, when you try to do a decompression, when you go straight to the OR, that's has to be done at the patient bed.
And another short question to the detection of the toxic megacolon. If I remember correct, I mean, the distension is just 6 centimeters, right? Is the definition. It's a relatively mild distension. And how can I detect? I mean, it's not such a specific distension. So how can I detect this disease?
Also a very good question. Of course, this has to be put also in the clinical setting. If you see a dilation without clinical signs, it's hard to talk about a pseudo-obstruction. But if you do, then you have to put this into the clinical frame. There's a difference between the diameter of the cecum and of the transverse colon. The limits are a bit different.
I mean, just one technical question. If you have to resect, what kind of anastomosis do you prefer? If you have a colonic obstruction and you have to resect and the colon is dilated and you want to do an anastomosis, which kind of anastomosis would you?
If you have, for example, an obstruction on the right side, we usually perform a side-to-side anastomosis, stapler anastomosis. And if you have a left-sided obstruction, usually you also do an end-to-end anastomosis, also usually performing a stapler as well. There's always the question: do you trust your anastomosis, or do you need to have a protection and in addition to that put a loop ileostomy?
Okay.
Good. Thank you very much.